Okay, so the session now is talking about barriers to a good doctor-patient communication in a systemic manner. So the systemic barriers, where we see it from our regular processes. So this little video, the minute Veena said this clip came to my mind. And the gap here in communication is between the doctor and the patient. The diagnosis is the same. Patient's going to not have a very long life. But what the doctor feels is it's a very serious diagnosis, and the patient isn't taking it serious enough. And the patient feels that he's going to live life, whether it's 6 months or 60 years, it really doesn't matter to him. So it's a perspective that the two people bring and the communication that they bring. The second, why I wanted to show this clip was this is how cinema shows doctors. So over time, I was looking for several other clips, and sadly, I didn't find others. But there have been episodes where doctor to Bhagwan hai, right? और अब हम कुछ नहीं कर सकते हैं, अब तो आप भगवान के नाम पे घंटी बजाइए. So those kind of clips are there in all movies. There is a systemic understanding of what a doctor should be and what a doctor should look like and what a doctor should say, right? That comes from a lot of our movies earlier, now through media and social media. Then doctors have a systemic barrier to communication, and this systemic barrier comes through their training during medical school. So in India, there is definitely a class I remember that used to be on empathy, and there is some classes on communication, but much of it is on technical learning than on communication. We learn communication, and if many of us are from government institutions, the kind of learning of patient communication is very different from what we will face in private practice. So with that little background, may I start with Dr. Sunil Mishra. So Dr. Mishra, so I actually, let me introduce the team here, the panel here. So I have Dr. Jasjeet, Dr. Sunil, both are endocrinologists and working in tertiary care settings. Dr. Kaushal is a hepatologist. He's also worked in tertiary care settings. Dr. Prabhat is a physician, and he's working in a private setting wherein his practice is his own. So it's a slightly different perspective of care as well. So starting with Dr. Sunil. So I know that because there is an acute care, like Dr. Aditya was saying, that there is acute care treatment in which the patient is in crisis, he comes to you, communication is very simple. But in chronic disease, how does communication with patient happen, and how does it grow over time?
It is difficult to understand from our end also, because as you rightly said, the training, lack of training is there for the chronic care. So the disease which we are treating, diabetes, thyroid, and other endocrine disorder, hardly been taught during the medical education. And for even MBBS and for our MD, there was hardly any case of the endocrinology to qualify the MD examination. But now we know this is a pandemic of diabetes, and we know it's the source of so many other complications like kidney disease, like eye disease, and other. But in medical curriculum, there is certainly a lack of the education regarding chronic care. So I have a paper with me. So you please forgive me if I read from this.
No. Right? I have a paper also.
It's difficult for me to remember each and every point. But before I start communication with my patient, I ask him, "Kya sunna kya chahte hain? Ab kyun aaye hain mere paas?" So many times that we discussed, Sham and first time, patient has taken opinion of the many patients. Like a patient of simple thyroiditis will come to you just to re-endorse the viewpoint of other colleague who has given only beta blocker, not given the anti-thyroid medication. सबसे पहले कि हमें जानना क्या है, सुनना क्या चाहते हैं. सेकंड मैं उनसे पूछता हूँ कि आप सच सुनना चाहते हैं, झूठ सुनना चाहते हैं. तो मैंने क्या that breaks the ice. That breaks the ice. वो थोड़ा सा रिलैक्स हो जाते हैं कि आप ये घास नहीं उठा, थोड़ा सा आराम से बैठे. तो फिर नेक्स्ट तो फिर मैं आपको सच सुनना चाहता हूँ, मैं आपको दोहा सुनाता हूँ सुंदरकांड से. So उसमें लिखा है, सचिव वैद्य गुरु तीन जो प्रिय बोले है आस, राज धर्म तन तीनी कर वही वे गई नास. वो समय तुलसीदास ने बोला है, सुंदरकांड में लिखा गया. सचिव हो गए, सेक्रेटरी हो गए, वैद्य हो गए, डॉक्टर्स एंड गुरु, ये तीन लोग राज करते हैं और ये भय की आशा में डर की वजह से अगर झूठ बोल रहे हैं तो उस राज्य का नाश जरूर होगा। एज ए टीचर, एज ए सेक्रेटरी, वी नो सेक्रेटरीज, and as a doctor also, we have a responsibility to tell the truth. Truth may be bitter, but हमको ये accept करना. So that is what with big eyes. Second thing regarding the chronic care, there is epidemiological transition. We know scientifically India is a midst of the epidemiological transition. पता नहीं कब तक रहेगा, मुझे भी नहीं मालूम है। इतना हम तो acute को भी नहीं खत्म कर पाए हैं और chronic ने तो हमारा मुश्किल कर दिया, and that is putting a lot of stress on the medical care. ये बड़ा चैलेंज है. So just let us start a talk between patient and doctor. कैसे बात होती है? अब मैंने पूछा कैसे हैं आप? मैं ठीक हूँ. इज ए पेशेंट ऑफ हाइपरटेंशन. ठीक है डॉक्टर साहब, सब ठीक चल रहा है. आप दवा ले रहे हैं? हाँ लेते रहते हैं, बीच बीच में कभी छूट भी जाती है, फिर बीच में हमने दूसरा और ट्रीटमेंट कर लिया. Challenge here is that what is happening between this talk and on one fine day that patient meets me in some marriage ceremony. तो डॉक्टर साहब मैंने बीच में आपका ट्रीटमेंट छोड़ दिया था, मैं वहां चला गया था, वहां पर जाके उन्होंने आश्रम में गया, मेरा सब ठीक चल रहा है. ठीक, अब आप क्या बोलेंगे इसमें? So now you don't know what is happening with the treatment. क्या ऐसे वो पेशेंट का ब्लड प्रेशर ठीक भी चल रहा है नहीं चल रहा है. You know the consequence of the blood pressure. इससे बहुत सारी प्रॉब्लम होनी है भाई. सेंट्रल पाइप का प्रेशर बढ़ा हुआ है, सारे ऑर्गन में डैमेज करने ही करने, सारी यूनिट जाएंगी इस कॉन्डिमोनियम की, चाहे वो ब्रेन हो चाहे वो किडनी हो, कुछ नहीं बचने वाला. बट वो मानने को तैयार नहीं. अब कैसे आप मान लेंगे? बिकॉज ही इज नॉट सीइंग द व्हाट इज कमिंग टू हिम. ठीक है, फिर आप चैलेंज क्यों है, फिर क्यों हो रहा है चैलेंज क्यों है? सो एक ट्रेनिंग इन मेडिकल स्पेशलिटी हमने बात करी है उसके बारे में. लैक ऑफ इंफ्रास्ट्रक्चर. अब एक्यूट केयर में क्या होता है, इट्स ऑल आपके पास में परेशानी आ गई, आप फटाफट कर रहे हैं, आप उससे कंसेंट साइन हो रही है और अंदर काम भी चल रहा है. सो यू आर नॉट वेटिंग फॉर एनी पेशेंट नोज, पेशेंट अटेंड रिलेटिव नो, तो आपको टाइम नहीं है इतना सब करने की फटाफट. क्रॉनिक केयर में हमारे पास इंफ्रास्ट्रक्चर है, हमारे एजुकेटर्स हैं, हमारे बाहर के स्टाफ हैं, उनको सबको समझना होता है, उनकी ट्रेनिंग तो है ही नहीं. तो ये कैसे इसको हम आगे बढ़ाएं, पेशेंट की अंडरस्टैंडिंग कैसे हो? And in all these, the communication does play a big role. Right? So it has to be a collaborative care. Collaborative care, say what I means with collaborative care. So I shall start giving the solutions also here. Yeah,
Please do.
Yeah. So collaborative care means it has to be interaction. It should be a shared agenda between patient and doctor. हम दोनों को बात करनी चाहिए आपस में. Agenda should be shared. It's short. Not my way is the highway नहीं होना चाहिए. मेरे रास्ते चलोगे, बाकी ऐसा करना, बाकी कई बार आते हैं प्रिस्क्रिप्शन को उधर कर दिया, ऐसा नहीं हो सकता है. देयर में बी अ डिफरेंस इन द ओपिनियन. बिहेवियरल चेंज जरूरी है फॉर क्रॉनिक केयर इन कोलैबोरेटिव केयर. गोल शुड बी सेल्फ एफिकेसी. पेशेंट को सेल्फ मैनेजमेंट जरूरी है. आवर जॉब इज 5% इन एनी क्रॉनिक केयर, 95% जॉब इज देयर्स. सो हम बोलते हैं मेरा काम तो खत्म, अब आप शुरू करिए. हाउ यू विल लिव बेटर, इट ऑल डिपेंड्स अपॉन यू. फाइनली द डिसीजन इज मेड बिटवीन द पेशेंट एंड द केयरगिवर. Now, when I come to communication strategies, so usually we have to 5 things which we do in day-to-day practice, but थोड़ा सा point wise लिखे हैं, इसलिए मैं पढ़ रहा हूँ इनको. So set a shared agenda. Whenever we discuss with people, we have to share shared agenda. भाई हम क्या चाहते हैं? चलिए ठीक है, आपके केस में आपको 25-year-old young person comes with a diabetes, high sugar के साथ आया. अब he is not aware कि अब क्या होने वाला है उसके साथ में. अभी तो उसको केवल बेलेनोपोस्टाइटिस हुई थी, जेनेटल इन्फेक्शन हो गए थे, आ गए हमारे पास में. सो वी स्टार्ट द ट्रीटमेंट ऑब्वियसली, बट नाउ ही इज रिलीव. नेक्स्ट विजिट ही कम्स, शुगर इज लिटिल बिट बेटर. तीसरी विजिट में आता है, उसने सब बंद कर दिया, सिम्टम्स नहीं है. नाउ द प्रॉब्लम इज दैट इज जेंटलमैन, इफ यू लुक एट द एक्सपेक्टेंसी ऑफ द लाइफ इज लॉन्ग, chances of the chronic complication are going to be, which I know, but now you have to make him understand कि इसको क्या होने वाला है. तो हमको उसको एजेंडा सेट करना है. यू आर यंग, यू हैव टू हैव अ गुड टाइट शुगर कंट्रोल. अब आप क्या कर सकते हैं इसमें? सो जेनेटिक्स यू कांट चेंज. आप एशियन रेस हम भी वो भी नहीं चेंज कर सकते. आप अपना वेट चेंज करिए, लाइफस्टाइल चेंज करिए. दैट वी हैव. सेकंड स्टेप इज आस्क, टेल, आस्क. पूछिए, बताइए, फिर समझाइए उसको. So we have to understand what they want to know, what is the lack of the understanding to them. उसको हमको बताना होगा. The biggest challenge in the chronic care is the learning and de-learning. एक तो हमको लर्निंग करनी है और डी-लर्निंग भी करानी है. De-learning is most difficult.
Hmm.
जो वो सीख के आए हैं उसको भुलाना और उसको नया पैटर्न समझाना it's challenge, but that is what we have to do and assess readiness to change. We have to motivate the patient and tell them the consequence of a poor control of diabetes or any chronic disease, self-management goal, and finally we have to close the loop. लूप क्लोज होना जरूरी है बाय मिसअंडरस्टैंडिंग की दूर होनी चाहिए, डिस्पेल होने चाहिए एंड हरी फिनिशिंग। आपने समझ, आपको लगा कि आपने 15 मिनट में सब कुछ बता दिया पेशेंट को, आपने बहुत अच्छा काम किया जी, आज तो पूरा लेक्चर दे दिया। आप हमें 15 साल लग गए हैं, 20 साल हो गए हैं, उसके बाद भी आज हम हर दिन नया चीज सीखते हैं। हाउ कैन वी एक्सपेक्ट दैट 15 मिनट में वो पेशेंट सब कुछ सीख गया होगा? नहीं पॉसिबल है। ठीक है, सो लेट हिम अंडरस्टैंड। हो सकता है उसका 5% ही हमारे वो स्टॉक का वो सीखा होगा। लेट हिम कम बैक अगेन। आप इतना सुनिए, अभी नेक्स्ट टाइम आइए फिर बात करते हैं। सो वी हैव टू डू दैट।
So expectation setting, as I understand, is very important according to you, and a shared decision making. So it's a give and take. It's not an individual doctor telling ki ye kare. But Dr. Prabhat, coming to you, how do you feel? So like he is in a tertiary care setting, although he says he will spend more than 15 minutes with the patient. I really don't know. But in a private setting such as yours, wherein it's an independent practice, how do you feel? Is there a different attitude of the patient? Is there a difference in time or commitment or the kind of cost of care, especially with chronic diseases that you face?
Thanks Pooja. First thing which I want to say is that कि इस प्रोग्राम में जो हम डिस्कस कर रहे हैं,
see, I like it. He went to Hindi.
Yes. तो ये जो चीजें डिस्कस जो कर रहे हैं, ये हमारे पॉइंट ऑफ व्यू। These are not of organizers. These are not shared by us.
Yes.
There can be few controversial points or points where we can argue a lot. Let me have a liberty before I answer this. Dr. Kaushal, आपने ना NCR के 3 बड़े इंस्टीट्यूट में काम किया जहां से मुझे मालूम है, which are all tertiary grade. In textbooks or in newspapers or in media, AIMS is number 1 in all aspects. Now, I just want to ask you, what is the difference between AIMS and the other setups which you have worked in? The care, the problems, the barriers. Then I think I will be able to answer
The communications.
this thing much better from my point of view.
Right. I think that is a very important point he has raised. We had not even thought about it.
Yes.
And since he's just brought it up, only one thing, if I have to say, when I moved from my first private practice was Medanta. So when I moved from AIMS and ILBS, I moved to Medanta. And the first thing I realized was, in terms of patient satisfaction, was symptomatic relief. All right. I don't know whether he wanted to hear this or not, but that was my observation.
I want to hear everything.
Yeah. So that was my observation. One point which was totally different from AIMS was symptomatic relief. In
Yeah.
AIMS, the emphasis was on making correct diagnosis and following strictly the guidelines of management. Whereas in a private setup, the first thing was first give relief, then we'll talk about the final diagnosis and the final whether you're following the guidelines or not. That was not the emphasis at AIMS, and that made a huge difference in terms of patient satisfaction. There, I don't think we were even concerned about patient came with pain abdomen. I'm talking about chronic. Acute, you have to act immediately. I'm talking about a chronic problem, say comes for pain abdomen, and your major focus was these are the differential diagnosis. You get these tests. Come back to me next week. He will not get an appointment after next week. He'll probably come after 2 to 3 weeks. Till that time, he will be suffering.
But Dr. Kaushal,
You will give him pain relief after 3 weeks. That was the emphasis.
But what his question and what we are talking today in the panel is about communication. So was there a difference in communication styles in both the settings?
Yeah. So
or something that
communication,
you've learned?
So I think we were more communicative there than
At
we were
AIMS.
here.
At AIMS?
Yeah, and I think the major problem was lack of time. There we were not concerned about time. We had
Yeah, ample.
any amount of time. which was not present here. There were 10 patients waiting. They might be shouting. The previous patient has not left the clinic, the room, and you just want him to be out so that you can see the next patient and the next patient who are already shouting.
Yeah. But so I guess that's what he wanted to hear.
No. This was just.
No, the focus in
Is
improving
on
the symptoms
treatment.
is in private setup. Yeah, otherwise the patient will leave.
Mm.
You don't want that to happen, so you want him to have relief of his symptoms
First.
and then move
Treat
on
the
to
disease.
the next thing.
Yes.
Exactly.
That is a function agency. The hospital, the patient is at a lower level, you are at a higher level, your requirement, expectations, yourself and the system, co-communication is less. Here, it is a very transactional relationship, so they have more agency, the patient, and you're aware of that.
Still but still, so many doctors spend so little time with the patient,
Yeah.
even in private setup. And the patient is still happy. Many of them.
No, why I raise this point is that, look, I am in a city where you have so many medical facility, and according to the latest survey, Gurgaon is one city which has the best medical facility in the country. And you have a civil hospital, and you have a tertiary grade hospital, something like a city. So why people will come to me,
Mm.
to a solo practitioner? So what they find? So I will start from there. Probably the type of patient which I see are early in their disease, or they have some acute problem, and they find going to tertiary center is either too costly because of their model of working, or the time taken will be too long, something like AIMS, and they have a myth, or what can they have an idea कि going to tertiary care can be expensive, it can be scary, and they may get same type of thing, same type of information at a little lesser cost in a solo clinic.
Mm.
So that's why people come to us. And as everybody is saying, we have lack of time. So we have to finish our communication within that particular time. Look, thing is that we cannot increase, हम 24 घंटे के 25 घंटे नहीं कर सकते, नो नेचुरल फिनोमेना, और हम सबके एक वर्किंग स्टाइल है, एक वर्किंग मोस्ट ऑफ टाइम क्वेश्चन कम्स कि जैसे अभी बात हो रही थी कि डिफरेंट डॉक्टर्स गिव डिफरेंट ओपिनियन. आई थिंक मोस्ट ऑफ द टाइम doctors are giving the same information, but its interpretation and the way it is discussed gives an idea that they are giving different information. So the communication, what I feel, should start from the level of patient knowledge. वो कहाँ से आ रहा है, किस टाइप का है, और उसको कितनी इंफॉर्मेशन एक विजिट में दी जाए. यदि हम उसे सब कुछ, जैसे डॉक्टर मिश्रा कह रहे थे, आप अपने 15 साल की पढ़ाई 5 मिनट में 10 मिनट में नहीं पढ़ा सकते. So that's why what I say कि कम्युनिकेशन उस लेवल का होना चाहिए जितना पेशेंट को आप एक विजिट में समझा सकते हैं, नेक्स्ट विजिट में और समझा सकते हैं उसको. हमें उस शब्दों का इस्तेमाल करें, डॉक्टर स्पीक जैसे आप कह रहे थे, वी हैव टू यूज ए लैंग्वेज जो वो आराम से, शायद हमारे डिस्कशन से बत्ती भी गुल हो गई तो
अभी देर शैल बी लाइट्स.
should we stop for some time?
We can continue.
Okay, we can
continue.
we can start, we can keep. I think they will, whether they will be able to
Transmit it.
yes, transmit हो रहा होगा.
चल रहा है. So they're saying
चल
it's
रहा है.
on. So at the end of the
अभी-
panel, there shall be light.
एक चीज ये भी है, अभी जितना डिस्कशन हो रहा था कम्युनिकेशन पॉइंट ऑफ व्यू से, हम सब कह रहे थे कि डॉक्टर्स को क्या करना चाहिए, क्या करना चाहिए। और जब डॉक्टर बीना का फोन आया मेरे पास कि वी आर डूइंग समथिंग लाइक ह्यूमनाइजिंग मेडिसिन, आई वाज थिंकिंग कि ह्यूमनाइजिंग का मतलब क्या हुआ। एंड what I feel, my personal view is that I'm across the table now. I'm not no more a doctor from patient point of view. Humanizing doesn't mean we should make things perfect. In fact, humanizing means we should accept imperfectness. Tolerance should come into the picture. And as a patient, I should also realize the person sitting in front of me is also not perfect. And we are discussing a subject which is far from perfect.
I think that is a very well said point. And I will bring that now to Jasjeet. So while he's talking about tolerance, do you see the patient perspective of a doctor? Do you feel it has changed over time in your practice?
So I'll just summarize the discussions Sunil, Kaushal, and Prabhat had made about few pointers where I would not entirely agree and have different point of view. One, chronic care in India is acute care wearing a cloak of chronicity. Patient doctor ke baad, let's talk about diabetes. He's scheduled to meet us every 6 months or 3 months. You go to the NHS and see they get reminders and everything. I'll keep it very short. But most of the visits to the doctors in our setup, I stand corrected, are triggered by metabolic problems like their blood glucose going up, physical problems like a fever or anything that triggers a visit to the doctor. So it's actually acute care wearing a cloak of a chronic disease known as diabetes. Secondly, when Dr. Kaushal was talking about his transition from the government to the private sector, he very rightly said, and to me, that is the reality, and the correct thing to do is to address the symptoms first. That's the primary bridge where we are building to the patients, and that directly translates to follow-ups and better results and all those things. And so that should be a part wherever we are. Constraints of time and all these things are genuine things, but we have to find a way out. I try my best to spend the time which is required for a patient. And Sunil is there. He knows I would leave the OPD for the last decade. But that's how I feel I can contribute to that part of the communication, which I've decided I have to do. Otherwise, chronic care cannot be successful in that way. Coming to the communication part, communication is always in between two people or a group. So it has stakeholders, one me, one the patient, and the family also. So when and the very relevant point that Prabhat made about humanizing it in living in not living in utopia,
So
is that
tolerance.
everything is not perfect, I think is the brilliant way to think, and something we should propagate in making our communications to the highest level, delivering patient care. Once that one thing of respecting the person in front of you generates or triggers that whole response and communication thing, and then we individualize and personalize. I communicate in different, Sunil, Kaushal, Prabhat, we all communicate in different ways. There's no textbook to communication. It's what I find the best way, which I see the responses from the patient side, both as behaviors and from metabolic responses, is what guides my communication with my patients.
Well, I really like the point that Dr. Prabhat said about tolerance. Tolerance even to the failings of the patient and the patient towards the failings of the doctor. This have to be created, and it can possibly be created in a solo practice. You want to say something? Sorry.
Not the patient to you. Also,
Yeah, but no, I'm still a little concerned about tolerance of doctors for patients' failings, because everyone knows diabetics in their families. So when you go to the doctor goes into a finger wagging phase. Ki, I had told you, you're not supposed to eat this. You're not supposed to do this. You've been doing it. I can see it on your HbA1c. How many parties did you go to? What did you do, etc.? Have you exercised? So that goes into like this, like this, like this. And then the fight begins.
Can I interrupt you here?
Yes.
This example which happened yesterday, there's a couple type 1 diabetes. So both are, I'm following up 2 instances. One was last Saturday and one was yesterday. So last Saturday, something or the other happened and I was not in that great a mood, indicating communications. And something had happened outside the room, which reflected in my communication with that. And they came inside and saw a different person. And they are so open to me. And they said, Dr. Saab, aaj to aap theek lag rahe ho. Maine kaha, haan, ye cheez hui thi, wo cheez hui thi, which reflected. See, I took it on myself to be honest with them.
Yeah.
What is going to happen? They go with that level of confidence. And yesterday we got a solution to a problem they were chasing. And together with the team, we were trying to find an answer to. And here comes communication and the tolerance part. If I donate the irritation or the lack of tolerance to the patient, there's no ways going forward.
So again, building up on that regarding tolerance, so how dogmatic the doctor should be regarding his advice.
Yeah.
So I think that this is very important and this comes with experience. So this was not there in me, say 15 years back. But now I have learned. For example, a patient has come and I strongly feel he should get a colonoscopy done. There's a high risk of having a colon cancer. So I advise colonoscopy. He comes back after 2 weeks. What right do I have to be appearing to him as a superior being? Like, why the hell did you not get a colonoscopy done? So I think this thing was there when I started my practice, and that has changed over last 15, 20 years. To give another example, for example, you gave the example of a creatinine of 10 and you tell the patient, please get a dialysis done. And 1 month, lo and behold, after 1 month down the line, he hasn't gotten done. So what gives you the right to be rude to the patient, which many doctors are, unfortunately. I have also been like that earlier. But I think over years, I have also changed. I have realized they have their own life. My job was to give them the right advice. Whether they take it, they may have 10 different problems of why they did not get a colonoscopy done or why they did not get a dialysis done. But I don't have that time to understand that. And I don't have the right to be angry with that, with them.
So I would slightly differ on that. So one, I agree with that the doctors should be less dogmatic, especially about when it is a non-life threatening condition. And because you can just give an example, like if somebody who's a maybe creatinine or 10 or 11, and if you know that he does not get the dialysis within a week or 2 weeks, obviously we are not sure. So I give an example, is there are 10 patients. If they will not get a dialysis within a 15 days or 1 month, 8 will develop some complication, 2 might not. So this is not an absolute thing, but this is a relative chances of getting complication are higher. Secondly, recently I had actually not one, twice, and 2 patients, kidney diseases, and they came with some weakness. We involved neurology, and they said the patient also has diabetes. They said this is probably a sort of chronic demyelinating neuropathy. We explained to patient his family, but family, because the neurologist is saying that he might get better, might not get better. They come with all sorts of questions, and there is no guarantee you can give that this will get better or not better, and this treatment is costly. And they decide. So then they come to me that the family or mother is not ready to take it. Go back 2 weeks later, I receive a call from family. Patient is getting sick. He is now his breathlessness. He has developed respiratory involvement. Patient on ventilator, and she dies. And they call me, okay, why didn't you tell me that patient may die?
Yeah.
So
it's true. So there will be
blaming now
you.
that you should have told that patient might die.
That is fine.
So I tell
agree
you
with
that sometime in a life-threatening situation, see, some diseases, they are life threat. It's like getting a colonoscopy. So there are some chances, maybe 5% or 2% chances that you might have cancer or you might not have a cancer. But then if you have a some cancer lesion or something like organ failure, then that becomes, you have to maybe give the stats. Maybe if not documenting, you need to give the stat. I don't know. Two of the 10 patient might not develop any problem.
No, I'm agreeing with giving the facts, giving the stats, telling them correctly what is required, documenting it in your file or documenting it in your paper, but not being angry with the patient. I'll give you another example. What I do. So we have patients of liver failure, whom you've today told that he will require transplant. There is a 50% chance of dying in next 2 years. The poor guy doesn't have the money. The poor guy doesn't have a donor. Okay, he will try his best to create these two things, but probably fail, and keep coming back with complications which are life-threatening. So at each such complication, I cannot, barge upon him and say, see, I told you, get a transplant done, and you're not, that's why this is happening. See, I told you. I have to understand, yes, he understands he's got to get a transplant done, but because of these problems, he's not getting it done. That's why.
No, I completely understand that. See, so liver failure, so that is a difference in disease. Like in liver failure, the liver transplant is very costly, and many patients of liver failure will live for years before they finally develop some complication or something. But in kidney failure, there is a treatment. There is second treatment to the transplant. There is a dialysis. Patient can live for many, many years on dialysis, even if he's not getting the transplant. And obviously, it is a choice. See, if there is a treatment option which is not available with most patients with liver failure, but there's a treatment which is costly but not so difficult. It is a difficult, dialysis is a difficult treatment, transplant is a difficult treatment, but see it, the quality of life, ultimately the whatever you say, the patient and family, they will decide whether they want to get a particular treatment or not. But this type of example that I given, this type things happens now. 2 or 3 people.
Yeah, I think.
That's exactly what we're talking about, the communication part.
Yes. So communicating. Yeah.
Rather than, it's more of a generic thing, how to communicate with, we took examples of a liver transplant and a kidney transplant. We're not disease specific discussion, but it's a discussion about communication, keeping in mind when you talk about life threatening problems, there is a medical legal aspect and a patient and a family aspect attached to that. So what Dr. Kaushal said was so very right, is medical documentation is very, very important. For example, in diabetes, hypoglycemia is possibly the most important and critical thing. It should be documented about education and the patient explained. So that communication part is possibly what we build.
I have a very serious issue with the whole medical legal and documentation. I agree that it is required. But in the garb of that, that is what we call in dehumanization, humanization. That is what I want to exist. Whether that is part of humanizing or is it exist. Our job is done because I have explained. But is the job done?
Our job
No.
is not done.
Yeah.
I understand.
Yeah, I think what you're saying, Dr. Bina, is that as doctors, the aim is to cure the patient and make the patient aware of the side effects and possible complications. Now, regarding the medical legal aspect, you have to understand that that's the reality of life today, right? If you don't communicate, if you don't document, and you have to make the patient understand and maybe sign a document that they have been explained that the repercussions or the side effects of this particular disease, if not treated, can lead to serious complications. Because now we are living in an era where the lawyers can come in and say, okay, आपका तो कहीं दिखा नहीं है आपने तो डॉक्टर ने बताया था जंगल में मोर नाचा किसने देखा. So the fact is nowadays the trend is towards documenting everything that you communicate to the patient. That is why now there are certain regulations where you have to take a video recording of the consent. So it has to be an informed consent, and it has to be in a vernacular language in which the patient understands. You may be talking gibberish, the patient may not understand that, but once the patient writes it, he or the attendant understand that what you have communicated. And that's very important part of life today as a doctor.
Yeah.
If
Can I
tomorrow
get
the patient comes up, yeah.
one example of patient?
Yeah, just let's complete.
Yeah. One
Let's just complete what Sunil is saying.
simple example. So like a 45-year-old gentleman comes to me. He's a smoking, chronic smoker. He chews tobacco and drinks alcohol. अब आप उसको क्या बताएंगे? He is diabetic also now. Now, so what I tell, how I communicate with them. देखिए आपकी जिंदगी बहुत लंबी है अभी आगे. तो first thing is reassure कि मेरी जिंदगी लंबी है. Two. So लोगों को अच्छा लगता है. Sometime I call my patients, आप मेरे को 1 साल बाद मिलिए. कुछ एल्डरली लोग हैं, बड़े समझदार हैं, बोलते हैं अरे डॉक्टर साहब आपने तो मेरे को 1 साल और लंबा जिया दिया, आप भी जिंदा रहेंगे, ये वर्ड भी रहेगा और हम भी मिलेंगे. मैंने कहा दैट्स ग्रेट. एंड समटाइम पेशेंट्स आफ्टर कोविड मीटिंग फॉर इयर्स फॉर I tell them, it's okay, both of us are here, is more important. Now coming to this point, how do I communicate? I tell them the major cause of death in diabetes is heart disease. अब मैं ये नहीं बोल रहा कि आपको होने वाला है, बट मैंने एक जनरल पिक्चर दे दी. एंड देयर आर फैक्टर्स व्हिच यू कैन चेंज. आप अपना वेट कंट्रोल करिए, एक्सरसाइज करिए और टोबैको बंद करिए. मैंने कहा टोबैको से आपको, स्मोकिंग से आपको हार्ट का रिस्क होने का बहुत बड़ा है. फिर बात मानेगा, फिर वो बार्गेनिंग करेगा मेरे से, फिर बोलेगा मैं अल्कोहल का क्या करूं. तो अब ऑब्वियसली अब यू कांट से अल्कोहल. मैं कहा देखिए अगर आप मेरे से सच सुनना चाहते हैं, क्या कर सुनना चाहते हैं, फिर वो ये बात आएगी. सो आई टेल देम सी अल्कोहल माइट नॉट बी बैड फॉर हार्ट, बट इट्स द 5% कॉज ऑफ द वर्ल्ड कैंसर इज बिकॉज ऑफ द कम्युनिकेटेड विद अल्कोहल. मैंने कहा आपको तो वैसे तो नहीं नुकसान कर रहा है, लेकिन आपका शरीर को जरूर खराब करेगा. सो दिस इज हाउ वी हैव टू कम्युनिकेट. होगा वो 6 months में नहीं बंद करने वाला है, probably it may take years. हो सकता है टोबैको बंद करें. Then I give an example of, you might have seen some big politician who has everything with him, but he has a mouth cancer and now see his situation. Right. So this is how, and big celebrities, they are having cancer. So yes,
So anyway, because Dr. Mehta has just joined us, so I'm going to bring the conversation one to him also. So because we're talking about communication and he is communicating in a critical care setting, because he's not on the panel, I'm going to still trouble him. Is Aap Sarvam, please get on the hotspot. So there are 2 areas I feel that, you know, as from a patient advocate point of view, that patients are concerned about most and feel that the doctors are not able to communicate very well. One is what is my patient's outcome going to be, and 2, what is my cost of care going to be? Because these are 2 factors that actually affect my decision making a lot. So how are these best communicated, and how in different settings? So whether it is from chronic care setting to in a tertiary care hospital, to an individual care setting, to a critical care setting. So this question just passes to everybody.
See, this problem I face every day. At least 2 patients, families I meet every day who want to shift the patient from another hospital to a hospital, to the ICU. After looking at the patient records and all, I clearly tell them that I will either be able to take the patient and help him. If the patient is terminal, I will say there is no point of wasting your energy and money and time. If the patient is salvageable or whatever, and there is some hope that we will be able to provide better care, then I tell them that, look, I cannot take the guarantee of how many, if he recovers, how many days he will take to recover. Because some of these illnesses, you cannot predict how long it will take. And that is when the family starts getting restless, because it costs a lot of money, particularly in the intensive care unit. So I tell them that it will cost you so much per day. So be ready for roughly so much of amount. I have no control over that. I can only assure you that we will do our best to try to save your patient. Then most of them are okay. Even when the bill mounts, if I've given them a ballpark figure or the number of days or months or weeks, whatever they want to stay, most of them are okay. Some of them are still not okay. Because that time they're desperate to bring their patient in, some hope to save the patient. And then obviously when the bill starts mounting and the patient doesn't respond, then they get aggressive.
So Dr. Prabhat, how do you face this in your practice?
I will go a little out again. Whenever a patient comes, my job is also like a traffic policeman sometimes, like what in Polish word you say coordinator. And we say about shared decision and all those things. We are talking last 24 hours about shared decision making and all those things. And what I personal feeling is that it makes the patient more confused than helping. And then they comes to me with all the data. And then I involved in their shared making decision. So that is the job of a traffic policeman, to which traffic should go and where you should stop. And my definition of best care is not the standard of care of medicines which are given in the guidelines. Best treatment is which makes you comfortable and which is best affordable to you. Reason is that most of us are paying from our own pocket, and in medicine, I think everybody spends beyond their limit when it comes to saving a life. So definition of best is best which can make you comfortable and which you can afford. And one thing which every my patient understand is that rule of medicine or principle of medicine is not a prolonging of life. It is to improve the quality of life. We have to learn death is an end point of life. We must learn. Every patient must understand, must accept this fact. And when they understand this fact, they have to say no at some place. We have to take that decision also. We have to stop the treatment now.
Yeah. So, Dr. Kaushal, coming to you, because what Dr. Prabhat is saying, he's saying it from a family physician point of view, because he has grown with the family. He can help them coming by this side of the family side and help them make the right decision. So how do you do that in a setting wherein you are not really engaging with the family or know them so closely?
I think the problem comes when a patient comes with an illness which we know will have an unpredictable course. So there are many illnesses which we know will have a predictable course. You tell the patient this will take a week, 2 weeks, 3 days, it's fine. But there are many patients, illnesses like, for example, acute pancreatitis, and he knows how unpredictable they can be. So a severe acute pancreatitis patient can go away from the hospital within 3 days, or maybe in the hospital and in ICU like Medanta for 3 months. So you can imagine what the consequences it will have, both emotionally as well as monetarily, on the family. So I think in terms of communication, once a patient like this comes, it's very important to tell them upfront that this particular illness, the course is going to be unpredictable. So I think to answer that issue, which was raised to you also, I think such illnesses, you have to tell them about the unpredictability.
Any comments from Sunil or Jasjeet?
I think we need to be very realistic in that, and obviously that's where the communication comes, starting from acute care to chronic care, or intensive care to chronic care. It's the one of the most important pillars is good communication, which has to be based on theoretical information, our experience, patient empathy, treatment choices, all put together. In those 10 to 15 to 20 minutes, we have to decide the priority list. I would at times make that list when I'm talking to the patient. Do I attend to the symptoms first? Do I give the treatment options more priority? But end of the day, with chronic care, we're meeting the patient again and again, gives us a greater opportunity to raise or complete that entire list of communication. Again, best is that.
One more thing I want to add to what Dr. Prabhat said about acceptance of death, about tolerance of unpredictability. I think that has, in favor of the medical professionals, has happened over last 2 years. People have realized what happened with COVID. So many families have now accepted. Earlier, I think once the patient, the family used to bring a patient to the hospital, acceptance of death or a negative outcome was very, very low. So they would become very aggressive when they would hear that such a thing would happen, or there would be a lot of fights when such a thing would happen. So now within last 2 years, people have realized that yes, there are failures even in medical profession. They know that the doctors have tried very hard all over the world, whether the patient is in US or UK or India. Even after best of care, patients have died. So many of them have died. So they have now come to a little acceptance. Yeah.
I'm not a doctor to begin with.
In all this discussion about doctor-patient communication, this patient is being identified as a single kind of patient. Now, when I talk to my friends and people, I see a huge variation in the people behaviors towards medical science. There are people who know a lot of medical science and are ready to follow a doctor to the T. And then there are people who kind of say, doctor to sab pagal hai, pata nahi kya bata dete hain, Baba Ramdev theek kar deta hai. So I think it will be very beneficial to understand what kind of patient one is dealing with. And I don't know, how you guys do that, but and for different kind of patient, there'll be different probably strategy for communication.
Very recently, one of my very close friends was diagnosed with a brain tumor, and he went to 2 neurosurgeons that I had recommended, and he spoke to both of them, and he chose one. I said, "Why did you choose him?" He said he was very matter of fact, and he spoke to me, right? And he told me that I was with that, and this is what it's going to look like, and this is the treatment course, and I felt very comfortable that he knew what he was talking about. The other gentleman spoke to my daughter, who is a medical student. So he spoke to her, and he spoke to her in a very technical language, and I was a bystander of the conversation. And he kept making a rosier perspective outcome. So he didn't like the rosy outcome and talking to the daughter. So, but maybe somebody else might have liked that. So I don't know which one likes what. How do you come to know? It's a very good question.
Yeah, so, why don't you go first? I'll speak after you.
Example, like we've been discussing about patient group. Last two patients who tried and said, so one patient was well educated, was poorly controlled on 2 agents. So I discussed about everything. This is a new drug, semaglutide, called method, a new drug, dapagliflozin, called at this point. So finally, after listening to all my communication, because अब बताते जो करना है just one more bit.
Yeah.
Once I was lucky that I well, learn at 14-year boy, came with a history of weight loss. It was 12% sugar, that was potassium. Family member, the mother, this was a lady who was one of my patients, relative brought the patient to me. So I'm going to communication and option to start getting not yet started medicine. Right now, my aim is to avoid the BK only. So that's how I'm from the voice and very intelligent boy. So आपको इंजेक्शन लेने पड़ेंगे अभी डॉक्टर्स ने इतना प्रोग्रेस नहीं किया है कि वो इंसुलिन को टैबलेट में दे सकें कि कभी तुम्हारी नीड it is not your deficiency, it is the deficiency of the medical science. So that is why I like that statement. अभी ये आगे होगा तो आपको ऐसे कर देते हैं.
So just to give you a little background, I'm not a doctor. I'm a designer, and for a number of years, about 20 years in communication. So while of course everyone here has profound experiences and you know the best on what you talk, but most of what we talk is actually what happens in the setting of a clinic. But from the design perspective, the journey of that patient is actually far wider. You are a very significant part of it, but you're a part of a journey. So if I may, the journey actually of communication starts perhaps for a patient where the patient really sees some symptoms or feels the need to go to a doctor and perhaps doesn't know which doctor to go to. Where do I know if I'm a patient, which doctor I need? I'm not talking about which doctor is in which person. I'm talking about the various kinds of doctors available. And excuse me for my layman language. But yeah, someone perhaps can identify that, yes, I need to go to a nephrologist or I need to go to a cardiologist, but there are many out there who don't know that. So family physician is perhaps one you go to, but there are some who then are in between. What I want to say is, from the perspective of doctors who practice themselves, or from the perspective of those who are in a larger system, do you really put it out there? What is it that the patient needs to come to you for in the language that the patient understands? So I'm talking completely from user-centric communication point of view. That's where it perhaps starts. Then there is, of course, every step at which there is communication. Communication can be about being able to access the doctor. Sometimes the process of taking an appointment with the doctor can be very taxing. At times, the communication between the staff and the patient can get pleasant or unpleasant depending on the expectations from each other. Sometimes some very easy tools like a simple message, which can say the doctor's running 10 minutes late, appointments are running half an hour late. These are all part of communication. They can really help the kind of communication that is going to lead to your communication. Because in that entire context, you are a part, and the communication before that and after that does have a bearing on the whole experience of the user. Of course, then there is this most important part where we've had such a lot of discussion since yesterday about communication between doctors and the patient in the clinic. I was, of course, Beena and I have been discussing this, I think, over the last 5-6 years and the initial discussion started around communication because Beena was looking for a suitable tool which would help her maintain records for her patients, which would also be user-centric, so that the patient does maintain a record and come back to her every time, because she said my treatment certainly depends in a large manner on the kind of record that I get from the patient. So there are, of course, certain tools, and there are some 3 lakh apps which are around. Of course, I'm sure there must be some that are suitable, there must be some that are not. So of course, these tools are a part of the communication. After that, of course, there is a prescription that every doctor writes. And if I may say, there is research, at least in the US, India, I don't know if we do that kind of research, but there is something that says 9 out of 10 people don't understand medical information. And as some of you rightly said, some terms come to you very naturally, and you put it very well when you said your daughter after school within 3 years graduated to the kind of language that people from the non-medical fraternity certainly don't understand. So yeah, there is a prescription. That prescription, of course, becomes like a Bible for the user. From your perspective, it's one prescription, perhaps you've written out of 100 in a day, but for that user, it's like a Bible that he has to follow for the next few days until he meets the doctor again. So, and then of course, there is a lot of other communication, between where the person goes to purchase medicines, what is available off the shelf, what is not available, what the chemist may give as the medication that is prescribed, or may say, "Arey, ye wala dusra brand hai, aap le lijiye." The challenge of being able to communicate with the doctor. A lot of times, I think, in my experience with doctors, and I've been meeting some of you over years as a patient, I think doctors are very, very happy to hear back from patients. When you don't return to the doctor, but they want to know what really happened.
So I'm hearing you say that the communication starts it's a very big spectrum, and it starts from a long time before the patient walks into the clinic or the hospital, and it continues way beyond that. So I guess that's a great message to leave this panel with. And so thank you all so much for a wonderful session.
I would request Dr. Yatin to stay back because for the next session, which is on communication in critically ill patients, in this whole communication thing, I really want to focus on one part which Shalini has put in very well.